very much. I think the issue of Nigeria implementing full-scale electronic health record system is not going to be that too easy. Why? Because first of all, we are yet to even identify or standardize the concept of what constitutes electronic health records. And because if you say electronic health records, in some countries of the world, it means you are talking about integrating the patient's records right from the time that patient was born up to the time he died or he died. And that means whosoever offers services to him, whichever department, whichever hospital, whether primary, secondary, tertiary, you can be able to access that information of that patient and treat him. That is the real concept of electronic health records. The content doesn't even think of any billing or inventory. It's just about the clinical care. And to be honest with you, there's not even any country of the world that has attained that. If you go through the studies of implementation of electronic health records across the globe, we look at Europe, we look at maybe UK, or what have you, you find out that they are fragmenting it step by step. For instance, the percentage of GP records in UK, a kind of digitization or making it computerized, that the GP system can be able to talk to one another within that. That one, they have achieved it. That one, they have achieved it. If you go to this general practitioner, any other time you go to any other general practitioner, you will have your records there. They even achieved pharmaceutical digitization. If the GP gives you a prescription, any pharmacy you go in the UK and you offer that prescription, your information is already there in that system. But when we talk about integrating that GP record to the secondary care, is very minimal. Not to talk of even teaching hospitals, not to talk, is still yet to be attained. What even surprised me or made that to be very scary is at a point when the National Health System of UK invested more than 3 times the budget of Nigeria in pounds in order to digitize the patient care. And they created a lot of consultancy, a lot of programs, a lot of investment up to a certain limit. And the contractors had to withdraw. There is a fine if you fail to complete a contract you signed, and it was a very big money. The contractors decided to pay that fine. And we do. Why? Because of so many things. He mentioned one thing, conflict of interest. It is not only in Nigeria, it's across the world. Because when you talk of computerization and electronic health records, you are talking about the IT people coming to the forefront. All this software, they are the ones to do it. They are the ones to tell the physician, this is how we want to design it. This is the only thing you will do. This is the only thing you do. And Prof himself was very fair to us when he told us, even him, as an ASU member, he doesn't like virtual, he prefers, and in other countries, for instance, that is. So, it's not even only in Nigeria, even there, the clinicians, in fact, the doctors and the other clinicians were at loggerheads with the contract people to the extent that thing had to stop. Even the leadership of that project was in question. Clinicians said, we should leave, we are the ones, we are not the ones to tell us what we are not to tell you what you should do. So it's not too easy. And for instance, what Mr. Tawfiq mentioned regarding integrating other form of computerization into a full-scale hospital digitalization is not too easy. When you were saying it, you know, we have what we call isolated databases. If computers can be able to speak themselves within a department like the laboratory information system, that's what we call electronic medical records. But they cannot be able to talk with a different setup. If you talk about the challenges of electronic health records, one of it is what is called interoperability. The software system there must be uniform and must be able to speak with one another, not only within the hospital but within the other hospital, so that when you pass information it will meet up with that. And health system is a very, very complex and complicated environment. Look at even the organizational structure of the hospital, and each time new structures, new methods, new procedures coming up and changing fast. Look at the professionals involved. Look at the sub-professional, look at the interwork relationship, and look at the number of the hospitals within the country. So if you put that computerization in your department, we can say it's just computerize something or electronic medical records, but not really electronic health. We even have, apart from the electronic medical records, electronic health records, we have what is called enterprise health information systems. And most of these softwares that are being operated in Nigeria are enterprise health information systems. People put it to manage and track their profits, their inventory, and their drugs level, rather than to optimize the care of the patient. So, whichever electronic medical records or health records you assume, at the background, the software will start introducing it as enterprise health information system. We have an Kano Teaching Hospital for that. So there's a lot of issues involved which need to be tracked. So we have electronic medical records, we have electronic health records, we have enterprise health information system. So you need to know which one are you dealing with. And before you even adopt that, it's just like a teller before he saw your applause, you need to check your measurement. Don't accept any software that brings to you that this is it. No. Okay, do it. And before you do it, there's what is called stakeholder analysis. That is, you first of all collect data from various stakeholders that will work with that software. Okay, what is the existing problem? First of all, okay, what do you want us to develop in that solution? And the person who developed that problem, you will ask patients all what they are encountering and this so that that solution will be developed and it will become a software that will be used. Then thereafter you implement. And when you implement, you monitor, whether it's efficient and effective. If not, you will review, evaluate, and of course upgrade. And even before you apply any software, there is need for change management. This thing is coming. You have to, what is change management? You have to unfreeze. That is, you have to change the negative perception of those people. Then you have to put the positive perception. Then unfreeze. You have to make sure they comply with the new things you brought in terms of regulation, disciplinary measures, rewards, and what have you, so that they will continue doing it. Otherwise, there's a lot of reasons why people will even object to the new technology. One of it is fear of unknown, fear of losing job, losing power, losing status, lack of expertise on that habit. I'm used to documenting something, now you want to force me to do. That is not what I've been using before. So a lot of things that may lead even to sabotage. If someone knows that you're going to lose job, you just go and cut some cables. So there's need for change management so as to make that thing acceptable, and it has to be, more of managerial. There are decisions that are political, but the decision to improve information through managerial is in order to improve efficiency and effectiveness and the quality of patient care. And a lot of other things will become a bottleneck in terms of the implementation of the electronic health records, electricity, because it is generating now, cost of data, server, training expertise, cost of software. Even software has a rule. You cannot just go and buy any software and apply because of the what do you call it, intellectual property rights. If you go and purchase a software that is not licensed, not from original vendor, it's unethical and it's a crime, it's a forgery. The hospital can be punished for that. So there's a lot of that. This interoperability standards is not there. So many things, costs, because healthcare is the one that is left behind in terms of digitalization. The airport, the aviation industry have done it. The transportation have done it. Banking system, to significant level, they have achieved it. And the healthcare is yet to achieve. But it's even better for the banking system. When there is a failure, there is a problem. Someone will not die. Maybe patient will only die if you cannot bring out the money to go and pay for his bill. But there are other alternatives again. But in healthcare, it's not a discrete industry. It's a patient care industry. If things are not done properly, people will die. So that's the reason why I'm always an advocate of the hybrid system, whereby you have both the digitized system and of course the manual system. So that when this thing fails, then we go back to the manual. Because there is no certainty as far as we are. Even you can see the LPC convention today, there is no certainty.
Thank you so much. We'll still move with the order that we followed the first time. One house, please. We all established now that there is a challenge in having a universal database for electronic health record, the implementation, and how to even go about it. So from the nurses care,